I'm supposed to be giving you a, more tech, self-management, a clinical voice. And yeah, I think it's pretty well established we need to change for loads of different reasons, not just a demographic tsunami, but also where we get our healthcare. One of the great things I liked about China was that they've got loads and loads of hospitals. So have we. Scale is huge. We visited a small city, 4.5 million people. When you think about that, what does that mean for us, 4.5 million people? That's Manchester plus Liverpool plus the northwest coast and taking most of Scotland, and that's in the city. So I'm used to tower blocks working in Kirby. We used to have loads. We've got less of them these days. But when you drive for half an hour through tower block after tower block after tower block, you realise you're dealing with scales that we would find hard to imagine. It's like Douglas Adams said about the universe. It's big, not that big, but so big you can't actually think of it anymore. It ceases to be impressive. It's bigger than a cathedral. It's huge. Where we get our problem here is about where we get our healthcare and the mindsets that we use to deliver that healthcare. Okay? Long time ago, as a junior doctor in the world of obs and gynae, I realised that I was asking, when I was clerking in day cases, I was asking the same questions over and over again, because the things the anaesthetist wanted to know and the things the surgeon wanted to know. This was 1990, and I thought, well, if I'm asking the same questions all over again and they want to know all these things every single time, the sensible thing to do would be to write it down, wouldn't it? And then I can go through that list every time. And when they give me the yes-no answers, I can put yes-no and a few details and whatever. I thought that sounds sensible to me, because I'm a lazy guy. I like the easy life. But we'll do that. So me and my 4 colleagues, we did this. We made this happen. We put this checklist in, and the gas passers loved it. Sorry, that's anaesthetists for anybody who's not technical. Gas passers loved it. And my consultant at the time, Miss Miller, not from the song by Queen, don't worry. A few people quick at the front. The rest of you just think about it, right? Thanks very much. Man with his face palm moment going on at the back. Sorry about that. Yeah, she came in and she hung a handbag over her arm, and she looked at me and she said, Dr. Mimnagh, this checklist you've done, it's not appropriate. I want it written legibly, and I want it written in full. Thank you. She's dead now, which wasn't a bad thing, really. Shouldn't speak ill of the dead. Don't. Sharp in, take a breath on the right there. Don't worry, I will offend everybody sooner or later. I am an equal opportunities offender. So, where we get our, another one as well, these are good, stick around. I can't wait to see my reviews on Twitter. The problem is, at the moment, we've got quite a few people who are in secondary care who I should be looking after in primary care. And I've got quite a few people in primary care who should really be in secondary care. And it's finding them and getting them sorted that's the problem. And equally down the other end of the pyramid, and I love pyramids really, been around a long time, we've got loads of people looking after themselves that I should be looking after. And equally, I've got loads of people ringing me up every day asking me to look after them in a way that's entirely impractical. He's been vomiting, Doc. Oh, sorry, Kirby. He's been lolling and burning, Doc. When did he start? This morning. I'm going to tick. I'm speaking to you at 8:45. When you say this morning, half an hour ago. Okay. Have you given him any paracetamol? No, I thought to wait and speak to you. Okay, good. Have you got any paracetamol? Yeah. Okay. Well, can you give him some paracetamol and then ring me back later? See how it goes. I kid you not. Last July, our practice moved to a new system where by you ring us, we ring you back. We then speak, discuss, whatever. A third of the people we speak to, we can solve over the phone. A third of the people we bring in within 4-hour target. Our own self-imposed target. Government didn't decide it. We thought that one up on our own. It's good. And a third of the people we do the right thing with. We find some way else of dealing with them. We arrange blood tests and then see them or send them to somebody more appropriate than me for sorting them out. We haven't had any extra money for doing that. I don't want any extra money for doing that. I just think it's the right thing to do. We need to get more parts of the system to think about what is the right thing to do. We need to get people like the consultant ophthalmologist at Aintree who came to me one day and said, listen, I've got this form, and if the GPs use this form, then probably most of the stuff that I'm doing that I shouldn't be doing in clinic, it'll get dealt with by the GPs. Came back to me 3 months later when he'd been in the job for 3 months, and he said, listen, about that form, realised that we are actually a cost generating centre for our hospital, and that any loss of activity would be seen as negative consequences by the department. So we won't be launching that form. He went from doing the right thing to doing the wrong thing. And that's about demand, really. It's demand from the patients, from us as population. Have we got any patients in the room, just out of interest? What, nobody else here got a GP? Failed. Yeah, my point, we're all patients, we're all users of service, we all take our chance on the NHS, and therefore we're all punters. And that is a stark figure, 2.5 visits per person about 10 years ago. Now we're up to 6 visits per person. We've not had a doubling of general practice. That's my whinge about being a GP over. And my point being that one size never fits all. We're working in so many different ways and so many different places at the moment. And how many people here are with the UK's most recommended bank? First direct customers, put your hands up. Okay, fine. You are so old tech. That means you lot worry about branch openings and stuff like that, yeah? Yeah? You're still into that kind of thing? First Direct has no branches. It's open 365 days a year, 24/7. I did ring them up on Christmas Day and check. They were dead chuffed. It isn't the UK's most recommended bank on the high street, as somebody else points out. Well, they have to point out on the high street because they're not the UK's most recommended bank. One size doesn't fit all in banking, but we have one size fits all in healthcare, or so we think. My premise today, and the reason why I'm here, I suppose, is that we need to think about segmenting our marketplace. Now, it's a shame Bruce isn't here, because that would be really interesting. You've come across things called, patient activation measures. Yeah? No, okay. Fortunately, the guy who identified himself as a patient is nodding. Thank God for that. Yeah, patient activation measure is how much you are prepared and able and various ways of looking after yourself. Okay, so the patient who rings up about the kid who hasn't given him any paracetamol, pretty well disactivated, unactivated, whatever the word is. Whereas the guy who sends me a little email with a list of all his blood sugars and his monitoring, his exercise regime, his rough calorie count, is fantastically well controlled as a diabetic and extremely well activated. And I think part of the problem we've got is that when it comes to our new tech and new ways of working and new ways of doing things, we throw it at the wall, see what sticks, and then if it doesn't work, we tell people it didn't work. And we don't look at who was using it and why were they using it. And one of the dimensions I think we need to get into thinking about is are the people using the stuff, do they have a health need? And are the people who've got the health need people who are activated? Because when you just simply 2x2 it, and let's face it, that's a great move for anybody who wants to be a consultant in the world, do a 2x2 matrix. These guys who are highly activated and have a significant need are health stars. They're the people whose diabetic control is fantastic. They're the people who really understand how to work the system because they spend a lot of time thinking about it, and they're the ones who get the most out of it. But they're not the problem. These people down here who are extremely activated about their health and have no health need at all, some people used to call them the worried well, but they are the black holes in the healthcare system because they will be in like Flint at the drop of a hat, demanding the CT scan for the headache and whatever else, and working the system to the best of their ability, consuming resources without any real gain to the healthcare system. That may be controversial, but hey, it's only us talking. And they're not actually really the problem, as you might have guessed from looking at the diagram. These people here are, because they're the ones with significant health need and low activation. They're the reason why in Knowsley, 1/3 of patients diagnosed with cancer are diagnosed in the A&E department. Well, you know, you just don't want to bother anybody before then. You don't want to take time off work. It's tough taking time off work. You just live with a cough for long enough. You drive. You know when you're driving along behind the bus and it's got, if you've got a cough for 6 weeks, please see your GP. Yeah, my patients are sitting in the bus. Okay, not getting that message, just putting up with it. And then when the blood happens, and usually it happens, God knows when, in the majority of the week when, as a GP, I'm shut, they turn up in A&E. And the diagnosis is made. 1/3 of the cancers in Knowsley diagnosed in A&E. They're the problem. Okay, these people in the bottom left, the ones we don't know because they're not motivated and they don't have a health need. They don't touch me as an illness specialist. They don't touch me as a national illness service. They don't touch me at all. They're working in gyms and concentrating on other things. But that time bomb, the people who've got the health need and we don't know about, the ones that are going to kill us. Okay, because as we all get older, they're the people that we're going to be worried about. How many people here have got a disease at the moment? Okay, would you be prepared to share information about it with others? Excellent. That's a social disease, they've got them. Ian will kill me for that later, but never mind. The NHS doesn't like people thinking differently. And I love, did anybody get the Roy Lilly newsletter? Yeah, brilliant. You remember his one about Morrison's car park? They put in hedges and whatever, and the population decided when they parked the car, they walked through the hedge and into the supermarket that way. And in the NHS, we put a fence up around it, and then we'd have security guards and stuff like that. Security guards wouldn't actually do anything, and they'd just stand there looking like security guards. But Morrison's, of course, widen it, put a path through, lay down some flags, make it work, because that's the way the population's chosen to flow. So in the NHS at the moment, we're getting upset about patients who choose to use A&Es as their general practice. Okay. Why are they doing that then? What is it about that? Is it that they can't get access to the GP? Well, in Knowsley, 87% of patients are happy with current opening hours. 13% aren't. Who are the 13% then? Well, they're drug, alcohol, domestic violence, ex-offenders. The domestic violence one I love. They're people who don't use their family doctor because it's their family that's beating them up. Yeah? Yeah, funny world that, isn't it? They need primary care in a different way. What alternatives to traditional primary care do we have? Walk-in centres. Okay, what alternatives in the middle of the night do we have? A&E. Okay, so is that a problem? Do we want to vilify them for using the system the only way they can? So, how many people here are techies? Okay, how many people here are clinicians? Couple. Cool. How many people here are managers? Condolences. See, the managers are great because they're grouped mostly in the middle. That's because we're only a few weeks away from an election. They couldn't be seen to be on the left or the right. They have to maintain their position. Quick note about evolution. Anybody familiar with evolution? Yep, good. Okay, excellent. So you remember dinosaurs, long way away, very few people saw them. They evolved slightly. We've now got some dinosaurs you never see, like crocodiles, very few of them still hanging around. And we've got lots of dinosaurs you do see, flying around, birds, great. Anybody remember telegraph offices? No, good. You didn't look that old. Yeah, they evolved into the red phone box, yeah, remember them? And now they're those little, weird little, have to stand outside and get wet kind of phone thingies, yeah? So those dinosaurs are still around, those dinosaurs still exist. Okay, they're just, falling in number. Some of those telegraph offices did evolve into the old phones, Whitehall 1212, in your home. The trim phone, do you remember that? Anybody here can do the trim phone noise? No, hopefully not. It's very annoying. The mobile phone, the portable brick, and then finally, the mobile phone that we all carry today. In 2017, there'll be more phones than people on the planet, most of them in China. Anybody remember computers? Big computers, room-sized computers, Turing-type machines, big jobbies. They still exist. They currently, I think in 2010, they sold 3,500 supercomputers in the world. See Tony Chaffel for details. Tony's probably got a couple. Tony, you'll remember the Commodore PET, won't you?
It's a bit insulting knowing that I thought I was only 21.
Steady on, Tiger. And the ZX80, I used to own a ZX80. How I envied the ZX81 boys because their screens didn't flash when they pressed the run key. But the ultimate evolution of the computer is the one that everybody's looking at now thinking, good God, is that the time? Hurry up, man. Actually that little device is really interesting because it's, how many people here are wearing watches? Put your hands up if you've got a watch. How many people here use their phone as their watch now? Okay. So there's actually more people using their phone as their watch. So that little device is now your telephone, it's now your computer, it's now your watch. What it isn't really is your healthcare centre yet. Okay. Anybody familiar with Ali Parser? Yeah. Anybody looked at Babylon? Yeah. Okay. If you haven't looked at Babylon, look at Babylon. 95 quid a year gets you access to a GP 8 till 8 via your smartphone and subsequent referral onwards to specialists. 95 quid a year, that's 5 quid more than I get paid to provide you with face-to-face care all year. Fascinating. But apart from that, we've got these things, big lab machines. Now, is anybody familiar with big labs? Got anybody here from Liverpool Clinical Labs? No. Big labs, there's lots of big labs around. Okay, and dying. And I don't mean doggies. We've made very little transition to the mobile phone health environment to date. We're kind of trying stuff, throwing it at the wall, seeing what sticks. Maybe some of it does, some of it doesn't. But at the moment, we're still very much on the mainframe. We're still very much big lab boys. We're still very much hospital people. You know, you want to get looked after properly, you're going to go to the hospital. Why should my kids see a GP when they could see a paediatrician if they come to A&E? A director of finance at a major trust not very far from here said to me once. I thought that's because you work in secondary care, you don't understand primary care, and you don't take the kids to the doctor anyway. Point being, in healthcare, we are so far behind the curve of evolution when it comes to mobile and tech, and we risk throwing stuff at the wall, having some of it stick and thinking that that's the answer, because we'll think that one size fits all. Because we know these things. I love this quote from Doug Hartree. Here's in the Mersey region, we've got the Hartree Centre out at Daresbury, which contains supercomputers named after Doug Hartree. And that quote basically says how wrong you can be, because Doug said that we didn't actually need any more of these computer things coming along. We got 3. What do you need? More than 3 for? And he knew, because he was actually the world's expert about how these big computers worked. Absolutely convincing. And do you know what? He was right. We didn't build any more integration calculation engines. Moved into computers instead, proper computers, electronic, good machines, and then micros. But Doug was right, and everybody that sat and listened to him thinking he's the world's expert on it would have thought, well, what's the point of me getting into computers, because Doug says this is the way it's going to be. Now, I feel that way about lab people, and you know, as I say, there's not many lab people here, so I can insult them too. Yeah, that when they tell me it's not worth doing point-of-care testing, yet when I take one of my dogs to the vet can do the bloods, quick sticks, and I can walk out with the result for the dog quicker than I can. In Kirby, we do bloods in the surgery in the morning, and the courier comes about 11:30. So if somebody turns up and sees me at 2 o'clock in the afternoon, the next time they're going to get bloods is tomorrow. And if the lab rings me at 5:30, like they often do, and says, we've got a guy with potassium here of 7, he needs it rechecking, then I've got to take a decision as a clinician, ring that patient up and say, your potassium could be high enough that it could kill you. Or it might be a way the sample's been transported, or the way the lab's processed it, and it might be an artifact. We need to get this done again. Do you want to wait till tomorrow and get it done again, and then wait till tomorrow evening to get your results, knowing that you could die? Or would you like to go to A&E instead? Now, I don't quite put it like that, but you get my point. Do I want to handle a risk for that patient? No, I have to let the patient handle a risk for that one. And the decision we often take is that it's going to have to be a trip to A&E, where the system will pay a fortune for £1.70's worth of blood tests to take place. Why? Because the courier only comes to our surgery once a day. Why does he do that? Because he's always done it like that. Well, why isn't there a later one? Because nobody's ever asked. There's no demand for a later one. Really? Have you asked anybody, is there demand for a later pickup? No. Okay, well, nobody will ever ask them, will they? So, the question is, who are you connecting? Tech's interesting. My parents, when they read the paper, one of them does it on a Kindle, the other one does it on an iPad. But they both read the mail. What can you do? Tech in kids, the figure here is that 75% of over 10s have got their own mobile phone, and I think it's 30% get their phone when they are 10. It's like a rite of passage. Go to the big school, get your phone. Everybody's kid. Who's got kids here? Put your hands up. Right. Leave your hands up if your child hasn't got a mobile phone. How old are the kids?
8 and 10.
8 and 10. So soon for you? 8. Brilliant. Okay. So if you're under 10, you haven't got a mobile phone, and the thing that happens when you turn to big school is get a mobile phone. Illness is the opposite. As you get older, you get the illness, yeah, but you don't always get the tech. Now, I think that's just the way we think about it, because we know that old people aren't really good with technology. Old people aren't really good with it. I qualify for Saga now, for God's sake. I'm old. I'm not bad with tech. So we need to be smarter about who we are, and this is where there's I don't know if we got put it in the pack, have we?
Yes.
Yeah, cool. It's in the pack, right? Okay. Have a look at that because it'll make more sense when you've got it in front of you. I think that there are a few dimensions that we need to look at, and these things are not one-offs. You can't be just a nerd, right? Because you're not nerd at everything. There are some things you're still a newbie at the same time. So when it comes to tech, I think we should be, and healthcare apps and how you like to access healthcare and practically everything that we think about, you can clarify yourself or place yourself somewhere on this scale. So me, I think I'm pretty well full-on metal jacket nerd, okay? And anybody that wants to take that up with me can take it up on Twitter. That's the way it goes. I know that's old, but I'm assuming you're not into Bebo anyway. So, full-on nerd, or are you part newbie? You can rate yourself either way. So you may be a 5 and a 5, you may be a 10 and a 0. You know, we're humans, we vary. Are you well? Do you have any illnesses? Okay, which end of the scale are you? Are you generally well, but you've got diabetes, coping extremely well with it? Because actually having an illness doesn't mean you're not well. Shouldn't mean you're not well. Okay. Do you like stuff that's given to you on a plate, or do you do it yourself? Are you the kind of guy that goes into the travel agents to book a holiday and says, just here's a couple of grand, give me a holiday? Or are you the kind of guy who ekes every last penny out of every single decision you make, and do you assemble it yourself because you know it's going to be good that way? In a similar kind of way, are you passive or active in your healthcare, or you know, would you use a device if it records your distances walked? Would you not use it if you had to turn it on to record your distances walked? Which way are you? And when you start thinking like that, you can come up with a little map of who you are, and that's me. Self-rated, so you know, you can see I'm kind of to the left of things, generally well, got a couple of things going on. Don't really like other people deciding my tech. I like to do it myself. I'm pretty active about stuff, but I'm equally lazy about stuff because that's the way it goes some days. And like I say, full-on nerd. Trouble is, when you look at the systems that are out there for me to use and start mapping them on, I've done it for an app called Map My Run, which is a great thing. There's that and Strava as the main two. How many people here are Map My Run users? Okay, that's good. That tells me a lot. And how many people are Strava users? Wow. Okay. It's funny. Oh, the guys at the back are all Strava users. Tells you something. Yeah. So I've done it here for Map My Run, which you have to be kind of active to use. You need to turn it on. You need to set the settings. You need to work out. You need to finish it at the end and press the publish to Facebook button or whatever. But you can then forget about it once you're running, because that's it. It records the data and does everything else for you. Calculates your stats. No figures. No spreadsheets. It's the kind of thing that you're going to use when you're well. Okay, I think, in terms of timing, it is something which you choose to use yourself. There's no GP out there saying, why don't you use Map My Run at this moment in time? But then compare that to the EMIS Access portal, which you have to jump through hoops to get, because it's our portal, not yours, you're the patient, it's your information, our portal. So bring in your proof of identity, prove to me who you are, and I may let you on it. You may then be able to see your medicines, your prescriptions. You do have to actually go and log into it and seek it, and it's a bit fiddly, and you've got to do lots of stuff. You can't just do it off your mobile phone at the moment, although maybe you can soon. And you would probably only use it if you had a long-term condition. So you can see we've got two completely distinct propositions there. Map My Run, EMIS Access. And I reckon probably for everything around this room, you could come up with a picture that says, this is what, you know, a live core. Is it something that you're going to use when you're well? No, actually, you're probably going to be a little towards having an illness side of things. Is it something that you can just fit and forget? No, actually, you've got to remember to take the thing out and use it. So you could probably work out your own pattern. Like I say, that was me. So you've got one of those. Fill it in at home. Think about it. See what you think. Send me comments. Winding up. Final thought. Learning from aviation. Everybody in the NHS is heartily sick of being told that we should learn from the aviation industry. Okay? True? Yeah? See, the difference between me and a pilot is if a pilot makes a big mistake and crashes a plane, he kills himself, as we saw, and takes a couple hundred people with him. If I make a mistake, I generally do it once at a time, and I can usually go home at the end of the day. So aviation is significantly different from healthcare. That said, there are elements in common, like the counterintuitive nature of making the right decision. Do you know this story about the bombers? They did analysis, the RAF, this guy, Patrick Blackett, did analysis of returning bombers. He was tasked with challenged with the task of saying where additional reinforcements should be placed on bombers when they returned from raids over Germany. And the answer was, stick it where there are no holes. Completely wrong answer, isn't it? It's completely wrong to think that. Why would you do that? Surely to goodness you need to put it where the holes are so that they... No. What the guy worked out, and it's quite sensible, is that every bomber that got shot down took a hit in an area that the bombers that came back didn't take a hit. Counterintuitive, just wouldn't do it. We got the same kind of problem. Up at the David Lloyd in Kirby, you'll see plenty of 23-year-old males spending an hour in the gym, getting buff, walking out, lighting up. It's counterintuitive, isn't it? It's wrong. Why? How can he do that? How can he spend time in the gym and then go and smoke? Well, actually, in his universe, it's perfectly congruent behaviour. Now, where are we? We're telling him, don't smoke. Get a life, doc. If we're going to do this person-centred behavioural change, perhaps one of the lessons we do need to learn from aviation is this thing called Boyd loops. Anybody familiar with that? No, okay. So jet fighters career. Issue about jet fighters is that you have to do things really quick, because if you don't, it's gone. And what this guy studied was what made a good pilot. And it turned out that a good ace pilot didn't wait for the other guy to make the move. A good ace pilot moves before the other guy does. Okay. So our challenge in healthcare is not to wait for our population to knock on the door and demand access, demand apps, and demand intelligence, and demand that they should be treated like proper human beings. Love the warfarin thing, by the way. Think about this for a moment. Let's launch a drug, shall we, which has serious consequences, can make you bleed to death, requires that you attend a regular clinic at the hospital, often get a phone call later in the day saying, have you taken your medication yet? You go, yeah, and then you say, no, you shouldn't have done. Right? Significant psychological cost, ties you to it. You're going to go away for 3 months? I don't think so. Now, if I launched that drug today, right, would you buy it? If I said to you, it's all right because everybody that takes this drug is going to have to employ nurses, right, to run clinics and run equipment, and there'll be a huge volume of lab tests done. Would you buy it? Why are we using it then? Because we're good with it. We know all about it. We've got plenty of clinics. We've got loads of people whose very jobs depend on those clinics staying. We've got people who like the social contact, going to the cattle market, as one of my patients calls it, and meeting all the mates in the clinic. Yeah, we're invested in it. We think it's the right thing to do. But can I tell you, if it started today, it would be thrown out, laughed out, a joke, something the NHS would never consider, but we run it because it's a sacred cow of the NHS. Boyd loops. We need to be thinking ahead of the curve, ahead of where our population are going. We need to be moving there now. We need to be setting up camp and staking it out. That's it from me. Have you got any answers?